Thank you so much for joining today. I'm Bonnie Mohan. I'm the Executive Director of the Health and Housing Consortium, which is sponsoring this convening, along with a lot of great partners that I'll be introducing later. So this is a two-day event, and really our goals behind putting this event together was to increase awareness and knowledge about medical respite, share learning and best practices from those who have been involved in it for many years, identify what are the barriers and questions that people may have about medical respite, help you all meet each other and network, and most importantly, to amplify the voices and experiences of those who've gone through medical respite as we plan for growing this program, expanding this program, wanting to make sure that their experience is front and center. Here's our agenda for the 2 days. So this is the first session. It's a 101 on medical respite for those of you who may be new to it or needing a refresher or just wanting to hear more about how medical respite is operating currently in New York City. After this session, we'll have a 30-minute break, and then at 11:30, we will hear from the State Department of Health about the new Medicaid pilot investment into medical respite, which will be launched later this year. So we're really excited to hear more about that program. Tomorrow is our day to really get into the details. So we have different breakout sessions where people can meet. Our first breakout session starts at 9:30. That's to organize people by stakeholder groups. So we have a group for hospitals and healthcare providers, for respite providers or those that are interested in providing respite, health insurers, MCOs, and respite participants. Following that session, we'll have another breakout, this time by topic area, so we can really dig into some of the aspects of medical respite program design, outcomes and evaluations, contracting and payment structures, and partnerships and collaboration. So if you haven't registered for any of those events, we really encourage you to. Harmony just dropped a link in the chat where you can see the whole agenda, and we'll conclude with a networking session, and those are going to be small groups where you can just meet people and exchange information. Really want to thank our planning committee. So in order to put this event together, we really wanted to make sure that we were hearing from the different stakeholders that would be interested in medical respite. So really want to thank these individuals who've contributed over the past 5 months, I'd say, to put this event together and make sure that this event is covering kind of the information that you all might be wanting and needing. And then finally, I want to thank the sponsors of this event, the Camden Coalition, National Center for Complex Health and Social Needs, the Health and Housing Consortium applied for this really wonderful program that they have around regional complex care convenings, and are honored that we were selected to put this event together through medical respite. So we're going to hear from Alex Lapira from the Camden Coalition to talk a bit more about the program.
All right, good morning. Thank you, Bonnie, Harmony, and team for having me today. My name is Alex Lapira. I'm a program coordinator with the Camden Coalition of Healthcare Providers, here to give you a little background on the Regional Complex Care Convenings Project. But first, take a step back and just give you some background on the Camden Coalition. All right, thank you. Oh, is there maybe, okay, perfect. So if you could go one slide back. All right, so the Camden Coalition was founded in 2000 by a primary care physician and provides short-term community-based care management in Camden, New Jersey. So that includes our Housing First program, medical legal partnership, health information exchange, that includes 5 hospital systems, FQHCs, corrections, faith-based organizations, and behavioral health. Might have missed a couple there, as well as coalition building on a local, regional, and national level. All right, next slide, please. So in 2016, the National Center for Complex Health and Social Needs was launched as an initiative of the Camden Coalition, and it was launched to be the home of the field of complex care. So you'll see there the National Center's goals are to convene field leaders to define and build the field of complex care, support practitioners with tools and resources, and to grow and connect the complex care community, which brings us to the Regional Complex Care Convenings Project. Next slide. Oh, perfect. Okay, so the Regional Convenings Project was launched in 2019 and aims to reduce the barriers to information sharing and collaboration on a regional level and to foster ecosystems of complex care. So host organizations, in this case, the Health and Housing Consortium, are selected through a competitive process requiring letters of support and a description of the barrier to complex care that they're facing in their community. So National Center staff, which is myself and my colleague Rebecca, work closely with the host organization, with Health and Housing Consortium team, to refine the purpose of the convening, plan the event, and provide limited funding. So to date, we've worked with 9 organizations across the country to bring together stakeholders in their communities. So if you go on to the next slide, you'll see this year's cohort is made up of 5 organizations who will be hosting convenings in Colorado, in Washington, Illinois, and of course, there's this convening in New York. Next slide. So it's been a pleasure working with the Health and Housing Consortium team, and very excited to see this convening come to fruition. I went over everything very quickly, so if you have any questions about the Camden Coalition or this project, feel free to reach out. I will drop my email in the chat. So thank you, Bonnie, Harmony, and team. Appreciate it.
Thank you so much, Alex. It's been really great working with the Camden Coalition and getting their insights as we put this event together. So we definitely encourage you all to check them out and maybe apply to do something like this next year. So why did we choose to do an event around medical respite when we were applying for this grant? Really, there's been a longstanding issue of patients who are experiencing homelessness and have complex medical and behavioral health needs, and they often are well enough to leave the hospital, but not well enough to go back to the street or the shelter or other place that they're staying. And so what happens is they often will get stuck in the hospital. And what's needed is a place for people to go to recuperate and get well and get connected to services and housing ultimately. And that's where medical respite comes in. So I just want to give a bit of, we're going to talk a lot about what's happening in New York City, but I thought it'd be helpful to get a bit of a national context for medical respite and a bit of an overview for those of you who are new. And of course, I turn to our partners at the National Healthcare for the Homeless Council, who've really been leading and championing medical respite for a very long time. And so the following slides are from them. So very quickly, what is medical respite care? It's a post-acute place for people who are experiencing homelessness to recover from illness or injury, not in the hospital, but in the community that's safer than the street or shelter where they might have otherwise gone to. It's a place to help people get connected to services, get a clean bed, meals, and most importantly, connected to housing. Programs look totally different depending on where you are in the country. No two programs are the same. They vary in the number of beds, where the facility is located, how long patients or clients are able to stay in the program, how they're staffed, where referrals come from, and what the admission criteria are. So we're going to see a little bit of how things are done nationally, and then we're really going to hear from the programs in New York about how they've set up their programs. It's important to know, in addition to what medical respite care is, what it is not. So it is not any of these skilled nursing facility, nursing home. If somebody needs this level of care, they are not appropriate for medical respite. And the reason for that is medical respite is for people who are, for the most part, independent in their activities of daily living. It's short term. It is not housing. It is not a permanent place. It's a temporary place to recover. Kind of at its core, medical respite involves these 4 components, certainly case management, some aspect of clinical care, connecting people to primary care and other outpatient services that they may need, and really helping them to manage their own care for once they are out of the respite program. Generally speaking, respite programs involve these elements. There's 24 access to a bed, so it's not something like a shelter where you may get a bed one night and not have it the next night. 3 meals a day are provided. Sometimes transportation to medical appointments is provided, a place to store personal items, and staff that will check on you regularly. Here's a look at, this is data from 123 programs across the country in terms of where these programs are located, how they're staffed, and what services are provided. So you can see actually nationally, the vast majority, or I'd say probably are located in shelters, co-located in shelters. Over 42% are there. That's not how it's been done in New York City. It may be something to explore because that's how it's done in a lot of other places across the country. And then after that, is standalone facilities. That may not be as much of an option here in New York City just because of space and how things are, but that is how a lot of programs across the country are in their own facility setup. The size of the programs really ranges. You can see from 3 beds to 210 beds, but the median is 17 beds. So these aren't huge programs, and I think that's important to note. This isn't a problem in like the thousands or tens of thousands of people who might need it, but for those that do, it's critically important and super impactful. So we're talking about a relatively small number of people and need and program size, but a really large impact. Here's a bit about how these programs are staffed. And so most importantly, case management is a huge component of this. Some programs also include nursing staff that may be brought in from externally through a system or be staffed in-house, social workers, and some have clinicians, nurse practitioners, and physicians that are also part of the program. Lengths of stay in the program also vary a lot. Most of them are under 30 days. You'll hear that's not how we've done things in New York. We've allowed people to stay a little bit longer, importantly to be able to get them connected to housing. But you can see there's a great diversity in terms of how long people stay in the programs. And then here are just some quick outcomes. Importantly, medical respite care has an impact on hospital use and service utilization. So we see decreased readmission rates, shorter lengths of stay in the hospital, better connection to outpatient services, and ultimately cost savings for hospitals. Even when some of those hospitals are directly funding the medical respite stay, they're still shown to be some cost savings for them. And also, very importantly, there's the impact on the consumers, those who are going through the respite program. So there's been shown to be quality of life improvements and positive impact on health management. Harm reduction is a core component of an outcome of medical respite that actually has shown to result in higher rates of treatment completion. And in general, we see reduced gaps in services. So people are getting better connected to specialists, to primary care, and other services that they need. I know I'm going through this fast. We'll be sharing the slides, so don't worry about that. If you're interested in learning more about medical respite in general on a national scale, the National Healthcare for the Homeless Council has developed this National Institute for Medical Respite Care. You can learn about it at this link. And there's an upcoming conference in Seattle where medical respite will be a heavily featured topic. So if you're interested, we can share information about that. And now I know I zipped right through that, but really importantly, we want to hear from those folks who have gone through the program. So we have Emmanuel Spiff, went through the ICL respite program. He was not able to join us today because he had work, but we were able to speak with him and record that interview. So I'm going to play that with you all now, if you just give me a moment to switch over.
I actually graduated. I hold a bachelor's degree. I graduated from the Rye University, and I worked a little bit in Dallas for UPS. I then moved to New York to actually pursue a new job position, and I didn't get the job. After a while, I ran out of money, and when I ran out of money, I checked into the shelter. And when I got into the shelter, my experience at the shelter was not good at all. And I spent a couple of months at the shelter, and I felt something about my health. I started feeling pains in my stomach, and I guess from lack of food, no money, my head started deteriorating, and I decided to sought for help. So I checked into the hospital. When I first arrived, I was met on a daily basis with nurses and sites and doctors, and they actually were trying to figure out how to assist me and provide me with the necessary help that I needed. When it was time for me to be released, I told them clearly I didn't want to go back to the shelter. So they said, okay, they were going to check me into the hospital and provide me with the necessary assistance that I needed. I didn't have health insurance. I didn't have I didn't have any public assistance. I didn't have any social security benefits and all that good stuff. And so I clearly told the doctors and the nurses my needs, and what they could actually do to help me. They then presented me with the option of either going back to the shelter or a respite program. The doctors mentioned that at the respite center is a place where people where they help or assist people get well. And I took that offer, and after a couple of months later, I was checked into the respite program where I was on supervised medication, and they welcomed me with open arms. Stability. The most I was provided stability, and my experience there is like nothing I've ever experienced before. It helped me acclimate back into society, being able to provided me a roof over my head. It provided me. They actually provided meals as well. They provided me with a care coordinator and a case manager that was able to meet with me several times a week to be able to make sure that all my needs were met. I told them I needed housing, supportive housing, and with which they worked tirelessly to be able to provide me with supportive housing and all of my social benefits that I needed, with which I was grateful for. It's absolutely different, and there were lots of aggressive people at the shelter. There was lots of fighting, lots of conflicts, and I am not an aggressive person or someone who likes conflict. And so I was glad I was able to leave the shelter because it was not good for my mental health at all. I'm still at the respite, and I am currently transitioning into supportive housing. My housing application and package has been approved. I'm just looking for an apartment agency that will be able to accept my package and accept me into their program. They provided me with the care coordinator, who is actually making sure that I have all of my necessary documents to be able to transition into that program, into supportive housing, where I'll be able to fend for myself. I'll be able to self-medicate. I'll be able to cook. I'll be able to have family come visit, and all that good stuff. What I want to say is that the respite program has been really helpful, and I think so far they're doing a good job with accepting people into the program. From my experience, since I've been here, I have seen folks. I've seen how my colleagues have been treated. the staff have been very diligent and caring and loving in their approach. And I would like to see more programs like that in the future. I will be more than happy to recommend the program to my fellow colleagues who are going through life struggles.
Great. Well, I wish that Emmanuel were here to thank, but we were so grateful for him sharing his experience. And he's just been really wonderful. He's one of our planning committee members, and it's been really wonderful to work with over these past few months. We are going to, we're a little bit behind schedule, which I apologize for. So we're going to get right into our presentations, but we are joined also by Raimundo Alvarez Quattrochi, who's from the Community Life program, and we're going to hear from him a little bit later. But first, I want to welcome Dr. Beverly Rodales, who's the Chief Program Officer at Community Life, to share about her program. And then after Beverly, we're going to hear from Dr. Victoria Pham and Ingrid DeBreo from the ICL Institute for Community Living Respite Program. Then we'll hear from some hospitals who are investing in respite: Deirdre Sekulich from Montefiore Medical Center, Marjorie Montplaisir Ellis from Health and Hospitals, and then finally Dr. Elizabeth Odens, who's from Empire Blue Cross Blue Shield Health Plus, who's also investing in respite. So we have a really fantastic lineup, and I'm going to hand it over to Dr. Rodales.
Thank you, Bonnie. Good morning, everyone. Bonnie, I think we will skip through the first page of the presentation, since I think you covered a lot of that in your initial opening remarks. I'd like to thank the Bronx Health and Housing Consortium for all of their diligent efforts in bringing awareness to the benefits and the importance of respite programs, regardless of what models, providers are running. It has brought a lot of attention and certainly highlighting, the needs and the benefits that individuals participating in respite programs receive. We started our respite program as a pilot program in 2011. It started as a pilot partnership with Montefiore Hospital, testing the cost efficiency of a respite bed along with the benefits of patients that were currently hospitalized, utilizing a hospital bed, were medically stable, medically clear, just didn't have suitable housing. It didn't mean they didn't have housing. It could have meant that perhaps the housing that they had in place wasn't suitable for them to continue their recuperation period. So we started as a pilot with Montefiore, and then soon after, Bronx Lebanon joined in the partnership and purchased respite beds. Today, we are operating 68 respite beds. Our respite beds are located in the Bronx. In Harlem, and in Brooklyn. We try to keep our respite beds on ground level or elevator buildings, such as our standalone building in Harlem. I'm sorry, Bonnie, I'm on the presentation. I'm on page 5. Thank you. The purpose of our respite program was to provide, as Bonnie just mentioned initially, provide safe transitional housing for patients who were medically cleared, but couldn't be discharged due to lack of housing or due to lack of suitable housing. We provide access to medical care and other supportive services. Who's eligible, who's appropriate, I guess I should say, for a respite referral? Well, the patient has to, 1, lack suitable housing, 2, need an environment in which to prepare or recover from medical procedures such as surgery, chemotherapy. We do have several patient referrals for IV infusions, or they're scheduled for other procedures. Either it's a colonoscopy, endoscopy, dialysis, wound care. The referral has to be independent with activities of daily living. What this means is they should be able to certainly do to ambulate from the bed or move from the bed into the bathroom by themselves. They should be able to use, the bathroom on their own, shower independently without assistance. They should be able to mobilize either on a wheelchair or with crutches or a walker independently. For those that are not, usually we take those on a case by case if they're connected to a home attendant and that home attendant covers majority of the time of the day, then we will look at those referrals differently. They should be psychiatrically stable enough to accept and receive care and not interrupt the recovery period of others in the facility. They should be sick enough to need more than emergency shelter bed for the night. Again, our respite model is not a shelter model. It is one where we don't provide the services on site, meaning we don't have physicians or nurses on site, but we do ensure that whatever aftercare need the patient may need is scheduled before the patient arrives to our respite model. Our staff ensures that those aftercare services are uninterrupted. For those that need wound care, it's usually done on site. We make sure that that provider comes on site and does provides the services uninterrupted. Patients should not be sick enough to require hospital level care or other medical care, such as a nursing home or psychiatric inpatient admission or rehab. Again, those referrals, if the patient needs such service, then they're not adequate for our respite program. They should have a condition with an identifiable end point of care for discharge. Patients should need to be willing to transition to the next level of permanent housing. Can be discharged to the respite program without program referral unit processing. Patients will be accepted regardless of insurance or legal status. I see there's a question in the chat. Do we receive undocumented individuals that are undocumented? And that really is dependent on our partners. We partner with Montefiore, we're Bronx Lebanon, H&H, Blue Cross Blue Shield. So we have that conversation early on a non-documented person, because usually that means that we're looking at an increased level length of stay. So it is all dependent on the our partner. Patients must be at least 21 years of age. Must agree to program rules and regulations. And patients requiring IV hydration will be assessed on a case-by-case basis. Referral procedure. Discharge planning is expected to begin as soon as the patient is admitted to the hospital. What this means is we do have an assessor. We have a LMSW that conducts the assessment at when the patient is at the hospital. And what are we assessing? Well, we're assessing that the patient meets all that eligibility criteria that I just mentioned, but we're also looking at what is their housing? Where were they before? Housing planning starts from the assessment period. What documents do they have? That helps us determine the length of time it's going to take us to generate or collect documents to prepare a 2010E. What type of income do they have? Are they able to afford a room? What type of family connections does that individual have? Maybe we can reunite them or reconnect them with family. So housing discharge plan starts at the assessment period. The hospital social worker calls the respite coordinator to make the referral, and the coordinator provides a bedside assessment, usually within 24 hours of the referral. We will make a decision for acceptance into the program based upon the above admission criteria and discussion with the hospital discharging planning team. The hospital provides to the program with patient consent the following information: initial history, physical and discharge summary, psychiatric or substance abuse history, and all pertinent social service information. That means, is the patient connected to a health home? Are they connected to any, who are they treatment providers? Who are their mental health provider? If there's substance abuse, who do they receive that service from? Family connections, who are their emergency contacts? follow-up appointments for specialty care, that is critical because we want to engage those providers before the patient gets to the respite program and confirm appointments and confirm follow-up care. TB status, oh, I should have included COVID status now. TB status, we're also collecting now COVID vaccinations. Is the patient vaccinated? Have they had COVID? So forth. Public communicable disease disclosure, and then referral for home care. Does that patient have home care connected, or is home care assessed at the hospital assessment? If so, then we will follow up and connect that service. Then, of course, we ask for 30 days of medication, regardless of how long that patient is being referred. We want to make sure that they have sufficient medication, not just for their stay, but in addition to. And then we identify with our partners the estimated length of time. What is our partner prescribing? Is this going to be a 1-week stay, a 2-week stay? We have patients that have 2 weeks IV infusion treatment, and then they return back to their supportive housing program. But we like to have an idea of what the provider's recommended length of stay is, and that becomes our target. It should be noted that significant time was spent working with social workers and discharge planning staff to understand and use the respite program. So prior to the respite program, we had a lot of conversation. Our president and CEO, Dr. Rosa Gill, invested a lot of time really understanding the hospital discharge planning process. What services do we provide to clients in our respite program? Well, bed and board, of course. Transportation, we ensure that transportation is available. So for patients that are going to dialysis, we work with the dialysis center. Transportation to medical appointments. We want to ensure, again, that their follow-up care is uninterrupted and that their road or their path to recovery is a successful one. Medication management for individuals that need help with medication management, we provide that assistance. We don't dispense or disperse medication. We just supervise the medication process. Case management, again, coordinating with medical appointments, ensuring that the individual attends the medical appointments and then communicates with service providers if there's progress or if there's no progress. We want to make sure that we're communicating. Individuals with wound care, we see that the wound is not healing appropriately. We want to communicate that right away to the providing team. Coordination of care, supportive counseling, transitioning, if you're having surgery or if you're recovering from serious surgery, that is a transition and certainly one that we want to be able to provide supportive counseling to. Wellness and self-management, we certainly want to ensure that the meals that we're providing to patients are meeting the dietary restrictions of the patients that we provide service to. And then housing placement. Our housing navigator, again, develops that discharge planning from the intake. What is going to be our plan of approach with that individual? The family, are they eligible for an HRA 2010E? We work with our own in-house housing team to identify and work with real estate and looking at room rentals for many of the patients that we serve. Advocacy and referrals, we're looking at if they're undocumented, where are they in the process? Do they qualify? We do have individuals that need to renew their residency status, but we know that that is an expensive one. So we reach out to agencies that can help with that process. And then connection, again, to medical, mental health. A lot of patients that we receive aren't connected to mental health. They primarily have a medical condition. And while in their stay at the respite, we assess that there is a mental health need. So we make those connections. Substance abuse, entitlements. Oftentimes individuals are not receiving SSI benefits, and we know how lengthy and tedious that process can be. So we certainly engage with a lot of advocacy providers. And I see Julie is on with New York LAG, certainly a very helpful one in helping us understand the process for a lot of those connections. And then we provide assistance with ADLs, how to budget your money, time management, how to coordinate all your medical appointments. We know that that can be overwhelming, healthy eating, and then recreation. We want to make sure that the socialization piece is in place and foster a community within our respite program. Housing, that's a heavy component in our respite model. Eligibility, application process, interviewing skills. How do you interview for a housing placement? Apartment seeking, apartment viewing, and then moving assistance. Family reunification, vocational assessment. We've had a few success stories of individuals that graduated, I think one from Lehman College, so took advantage of the vocational piece. Discharge from our respite program. Discharge planning usually occurs within 48 hours of the client's admission into the program. Staff activates screening procedures for food stamps, benefits, and employment assistance. We identify and arrange referral and placement in appropriate community-based housing programs or others. When an individual actually is a referral for supportive housing, we look into our own housing portfolio. Community Life operates over 2,200 units of supportive housing. So we look at our own vacancies first, and then we look at our partners' vacancies as well and make the appropriate referrals. We coordinate and transport clients to appointments for housing interviews and appointments. And then we arrange for transfer of clients out of respite to housing and assist with moving details. The length of stay in the respite program is determined by several factors: severity of health condition and how they recuperate, documentation of the severity of psychiatric condition. Oftentimes we have to work on stabilization of psychiatric so that they can actually, conduct an appropriate housing interview. Documentation of homelessness, then the severity of substance abuse if one is in existence, and then patients without government identification. That usually delays the process, especially if they're from out of state. We know that getting birth certificates from out of state takes a while. And then the undocumented, those usually the length of stay increases. Just to give demographics, and I know I'm running out of time, just the gender, 79% of our respite clients are males, 21% females. Under 21, while the criteria is 21, we have had a couple of instances where they weren't. So you see that 3%. African American are at 48%, 35% are Hispanic, 6% Asian. 83% of our respite population are covered by some type of medical insurance, 17% are not. Reason for admission, 65% are medical, while 35% are psychiatric. And then the discharge data, 38% are placed into supportive housing. You do see 19% transition into living with a family or friend. 12% are transitioned into a nursing home. These are individuals that recovery has, either they haven't recovered or the need for more supportive environment is assessed. So we make the referral to nursing home or assisted living. Thank you.
Thank you so much, Dr. Rodales. I know there's a lot of information to get through. We will be sharing the slides with everyone. We're going to go through all of our presentations and hold all questions for the end, but we are, for those of you putting your questions in the chat, we are collecting those and we'll get to as many as we can. So now I'll hand it off to Dr. Pham and Ingra at ICL.
Thank you so much, Bonnie and the team. You guys did such an amazing job. Just want to give you that shout out, and so glad to have everyone joining us for this very wonderful endeavor, and such a great level of care as well. Before Ingra talks a little bit about the program, I just wanted to give you some background about ICL and why medical respite is so near and dear to our heart. We believe in whole health, and as part of that, we have an ecosystem that really support patient who in lower levels of care. Every year, we serve about 15,000 clients, and every night, about 3,200 clients sleep with us, whether through shelter, through supportive housing, affordable housings, and so on. And so when patient comes to medical respite due to medical or psychiatric indications, they actually get what they need through that level of care. But upon sort of transitioning to the community, we have the level of care and services that could accommodate them, such as care coordination, shelters, different forms of housing. So that's how we're able to move them to the next level of care. So I'm going to hand it over to Ingra, and she'll talk about this level of care.
Thank you, Victoria, and good morning, everyone. It's a privilege to serve on this platform to discuss the ICL medical respite. So slide 1 is just basically an overall agenda of what will follow in the next few slides on the PowerPoint. Next slide, please. Our medical respite basically is strong partnership between ICL and collaborative organization to help individuals overcome stresses. Our medical respite, we started a pilot program in 2019. And as of today, we operate a 26-bed in Harlem in the YMCA. Next slide, please. Some of these are repetitive information, but pretty much the respite program is basically for individuals who are pretty much homeless. They are not suitable to return to the street or the shelter to recover. It is in the provider's clinical judgment that they feel that the individual need respite care. If they are currently placed in a congregate setting like a SRO, the SRO may not be able to meet their needs at this time, so the individual are referred to the respite. And some of this referral might be they need wound care, they need physical therapy, they need IV antibiotics. So those are temporarily individuals that come, and once they finish the treatment, they are usually returned back to their provider. In addition, the respite is also to improve health outcomes, to decrease readmission to the ED, and to increase the client overall improvement with adherence and medication. Next slide, please. This is basically our eligibility criteria for the respite. Our individuals are basically 18 years and older. They pretty much are homeless or housing insecure. What I noticed in the individual that come in with housing insecure, their current living situation they cannot return to. They may in a basement apartment that are flooded. We at the respite, we usually work with the landlord and try to get the place renovated and get the individual back to the living situation. They have to be able to perform their basic self-care, ADL skills. ICL do have staff on site 24/7. Every client that comes to the respite, they receive an orientation packet. If we see this is an area they're struggling with, we are very supportive. We give startup kits and help the individual through this process. We generally don't take sex offender at this time, only because of the location of the respite. In terms of medication management, we actually monitor and we don't administer meds. So our client come in pretty much have some basic of how to independently manage the medication. The respite goal in this area is to teach the resident how to name their medication, learn the importance of taking their meds, go to their doctor's appointment to get refilled, and most importantly, keeping a low count of their meds. So once they leave the respite, we give them that skills in able to manage their medication. Once again, the goal is for the individual not to deteriorate, follow what the discharge planning is, and move on from the respite. Next slide, please. This is some basic information that is required for the individual coming into the respite. Medical and physical information, referral for psychiatric evaluation is needed. And that's because if we have to do the 2010E, our goal is to have them find permanent housing. In addition, the discharge planner, the social workers of the hospital, they will make sure all wraparound services is in place for the individual. They will treat the discharge process as if the individual is being discharged into his or her own home. Next slide, please. So these are services provided at the respite. It's 25 to 90 days. It's actually a single room. The room comes with a refrigerator, a small table. The individuals share the common areas, which is basically the dining room. We have 24-hour staffing. We do provide 3 tailor meals per day, and we do try to meet the individual dietary needs. If the individual have food allergies, we speak to a vendor. If they're vegetarian, we try to make that accommodation as well. Medication is stored. We have a medication room. The clients actually report for meds, take the medication, staff encourage them. We do medication sweep. And one of the most important thing about the respite is the follow-up services. While they're with us, we make sure they go to the appointment. We provide transportation. We have residential aid that will actually escort them to the appointment. And we also review the appointment with the clients and teach the client how to advocate for themselves during the appointment process. Next slide, please. So pretty much this is the respite staffing. We do have a team leader. We have access to triage nursing if the staff have need any information around consultation. We do have social workers that does the risk assessment and all the clinical assessment. We do have case management, also known as paraprofessional, that actually help the individual develop their treatment plan, be a resource for information, and help the individual with the discharge process. And then we have the counselors, also known as residential aid. Those are the individuals that actually provide direct care support services for the client. And we also have security. Next slide, please. So this is basically a workflow of the referral process. And this whole workflow goes through, it's not that as complicated as it looks. It actually takes about 24 to 48 hours. What happened is the social worker sends the referral to community care. Community care sends the referral to ICL. ICL in terms will have to confirm we receive the assessment, we receive the referrals. After we receive the referral, we'll set a date for an appointment, schedule the interview, do the assessment, client agree, client is dropped off to the respite. Respite is already have an assigned case manager. After they have the assigned case manager, we review the orientation process and client is come on the process. We also have monthly meetings to discuss each patient that comes through the respite. Next slide, please. So these are some pretty lesson learned. This respite program, as I stated earlier, we started to operate in 2020. So there are times we used to have incomplete referrals. So we just have to refer back to the social worker. There are times when individuals was a no call, no show. Social worker was under the assumption that individual may have a phone. And when we follow up, the client didn't have a phone. There may be time when the patient may need a different level of care. There may be some cognitive decline, and the individual may not be able to answer certain safety question or even able to care for the basic ADL skills. Next slide, please. And now I'm going to hand it over to Victoria.
Yeah. So one of the striking things about our respite is that Ingra, who's our VP of Residential Services, and she has many different sort of business lines that she's taking care of, but she and her team knows everyone by their first name and is always very caring whenever she's on site. So I just want Ingra to know that your work is so much appreciated. But one of the things about our respite is that 100% of those who come into our level of care has chronic medical condition, and 100% of them are homeless. But they all come out discharged with discharge planning, being connected, 100% of them, to appointment, to services, unless they refuse. So with us, around 43% of patients coming to the level of care with mental health condition, around 8% with substance use, 13% with so many other components to it. And the majority of the patient have both medical and psychiatric components. Next slide. So we take discharge planning very seriously. One of the things that Ingra shared is that it usually takes us 1 or 2 days for the turnaround to see if someone would be accepted to this level of care. Discharge planning, obviously beginning on day 1, we make sure that we set up all the steps and getting all the paperwork in place to get the patient the best outcome possible. And one of the metrics that we measure is where the patient is going, in addition to all the appointments that we must set up for the patient. Family reunification, in our opinion, is so critical because housing certainly is, is one of the components, but having supportive network in addition to housing is also very critical. So 64% of our clients actually reuniting with their family and able to have supportive housing in such regard. 22% went to supportive housing alone without reunifying with their family, because oftentimes they may not have family. Private housing 13% and assisted living 2%. So that's ICL medical respite. We're open to questions. And one of the things that we track as well is the cost saving of medical respite versus hospitalization. I come from a world of Interqual. I was the one of their level of care creators, and I understand the importance of segmenting different levels of care and where it's most appropriate and the right level of care at the right time. So we try to segment out the cost saving of patient going to medical respite versus hospitalization. And over 1 year, just taking into account the time as well as the cost per day, and we try to take the national average for cost per day for medical hospital, we're able to generate this table for you all. This obviously is an average, but over time, taking December of 2021 into account, we're able to save $2 million in healthcare dollar for patient coming to medical respite versus staying at the hospital. So, yeah. Next slide. I think that's the end.
I think we had a Wi-Fi issue with Amy sharing her screen, but I think that was the last slide. So thank you so much, Victoria and Ingra, and we'll go right into, oh yeah, I don't know if you wanted to wrap up, but if you have any last thoughts, or are we good to move on? I think we had one last slide.
Oh yeah, so just lasting thoughts is that at ICL we have over 100 programs, and medical respite is one of them. And I think what we wholeheartedly try to do every single day is to move patient with much unfortunate background through the different levels of care that we have, such as shelters, outpatient clinic, or supportive housing. And because with that mission, we were able to succeed some of the goals that we have for each year. So,
thank you so much, Victoria. And yep, we'll do questions at the end. So I'm going to bring it over to Deirdre Sekulich from Montefiore to talk about from the hospital perspective.
Thanks, Bonnie. Hi, everybody. It's so nice to be here with you this morning. I'm not going to really talk a lot about our eligibility criteria because we've been working, as Beverly said, with the Community Life Respite Program since 2011, and their eligibility criteria is our eligibility criteria. So I wanted to talk a little bit about how we started it up and why we started it up on the hospital, and some of our challenges, some of the lessons we've learned, and some of the data and stuff that we use to show the success of this program. So as I said, we started in 2011, and it started off that in our hospital, we had one of our senior leaders was a real champion of housing issues and patients with housing issues. and actually started our Housing at Risk program in 2009. And respite was kind of a natural flow out of that program. We were discovering that we had a lot of issues in 2011. The length of stay for somebody, a shelter patient coming into the hospital, was very long. There was a lot of difficulties getting them back to their shelter because of some medical reasons. If they had IV antibiotics, if they had issues where they weren't eligible for shelter, but yet didn't have enough of a skill need to be in a nursing home, they got stuck in the hospital. So we started talking to Dr. Gill at Communilife, and we came up with the idea for the respite program. Back then, we contracted for 2 beds. So our contract was we would buy 2 beds at the ground floor of Communilife's first building on 146th Street, and we agreed to pay for those beds on a daily rate, whether or not the beds were filled. We currently, fast forward 11 years, we've got 4 beds and the ability to buy overflow beds with the respite program. We initially funded this program at Montefiore through cost savings from the ACO at the time. This program has shown to be just so valuable to the hospital that it's just part of the annual budget of the hospital. So it's paid for. We still have the contract that we will pay for the bed regardless of whether or not it's filled. I want to say some of our challenges, we were lucky enough that we had support and had leadership support. But some of the challenges initially were educating the staff, the hospital staff, about the program, about who is appropriate for respite. And I feel that's an ongoing issue. Turnover in hospitals is enormous. So we are constantly educating people on who is and who isn't appropriate for a respite bed. And I think we also realized we had to branch out and educate our other partners, not just the inpatient staff, but Montefiore has its own home care agency, and it was kind of educating the home care agency because they are the ones that are going in often to provide the nursing care or physical therapy to patients in respite. So just educating them about what the respite program is, what type of a facility, so that they're fully aware before they go in to service any of the patients. I think our biggest lesson that we learned early on was to have a centralized, very clear referral system into the program. So we are a very large hospital provider in the Bronx, and we have our housing team as the central intake for this program. If somebody makes a referral to us for respite, we came up with our referral forms, and that evolved over time also. We listened to the respite providers. We learned what was important to help fast track people through respite, not get them stuck in respite for longer periods of time. So we built our referral forms around that. And we have that everybody in the hospital can refer a case into myself and my team. We'll evaluate the case. We'll do a chart review. We'll look at the patient. We'll make sure they really are eligible for respite. And we will also look at the potential discharge plan for those patients. So when we're getting it down to the Communilife team, we're already saying, here's our estimated length of stay for the patient. Here's where we think they could be discharged to post-respite stay. We also, and I think it's important to note how you want to use a respite bed if you contract for respite. Do you want to have your patients go straight through and go to shelter, or if you want to try and link them to permanent housing? Some of the stuff that we use with respite, we get monthly reports. This data is built off our monthly reports and our annual reports. Our contract year runs February through the end of January each year. So we get a monthly report on bed use, the progression of the case, discharge outcomes, if anybody is re-hospitalized within the month. And we have bi-weekly conference calls with the respite provider just to discuss progression of the case and how we can help. And this is our data. And I wanted to give 3 years of data because we had, of course, the pandemic kind of turned everything on its head. So I wanted to give you an opportunity to see some of the years prior to 2020 with COVID. What we look at in terms of cost savings for the hospital, we look at the cost of putting somebody into the respite bed. And then we look at how many days would that patient be stuck in the hospital if we didn't have respite. We calculate the daily, the DRG, the daily rate for a hospitalized patient. And then we come up with how much we have saved by getting them out of the hospital and into the respite program. And then we also look at revenue generating, because if you have somebody stuck in a hospital bed, you can't admit somebody else into that bed. And if the average hospital stay is about 5 to 6 days, if you had somebody stuck there for 20 days, that's several patients you could have readmitted and actually gotten more payment for new beds. So we do an annual report back to the hospital board. I think the most important outcomes for us are people getting linked to permanent housing, people having a safe space to recuperate in the respite program. We get wonderful feedback. We also interview everybody we place to get feedback for our annual reports. And it's just health outcomes improve. And we've had several patients who, because of respite and because of the link to permanent housing, could then get listed for transplant, or were on chemotherapy and they had more adherence to treatment and had better health outcomes. And I know Harmony is wrapping me up, so I will finish, and I'm happy to take questions at the end.
Thank you so much, Deirdre. We're going to hand it right off to Marjorie.
Excellent. Good morning, everyone, and thank you for being here. Thank you, Bonnie and team, for putting this convening together and for allowing me to speak about this exciting work. Next slide, please. I'm going to be catching up in time, so anything that has already been said, I'm skipping over. You understand that respite is phenomenal and that our providers are ICL and the Institute for Community Living, also known as ICL, and Communilife. Currently, New York City H&H contracts with those two entities. We pay for those services directly. I'm also answering a couple of questions on the side too. It is not currently Medicaid reimbursable. We're talking about that later this afternoon with New York State. People who go to respite have Medicaid, they have Medicare, and they're also undocumented because we are H&H, the safety net provider. Many of our patients who go to respite are undocumented. We have served 570 people to date, and that's not people who are currently in respite now. We contract for 51 beds. We have a couple of beds in Brooklyn. The majority of them are in Harlem and also in the Bronx. The average length of stay is 43 days, and the average age is 47. Next slide, please. We've talked about all of these advantages, especially about housing case management, that our social workers, because they're providing clinical care in the hospital, have less time and capacity to be able to provide for our patients. Next slide, please. Lessons learned. This is the big one. So right now, the only way to make a referral to medical respite is from an inpatient unit. So you have to be in an H&H bed at an H&H facility in order to be referred to ICL or Communilife for medical respite. We have explored ways to look at how advantageous it would be to be able to do medical respite from the ED if we could do that really quickly. We also have our safety net providers that are ambulatory care settings that we've also been piloting some referrals directly from ambulatory care. We also have also looked at being able to make medical respite referrals from correctional health. So those are all to be continued places where we should be exploring. In terms of contracting, what we have learned is to start small and then build capacity over time and learn about what the need is through data-driven reporting from the facilities in order to contract for the suitable number of beds. It's also important from the start to set up data tracking so that you are monitoring the reasons why people go to respite, the kinds of services that are provided at respite. How many people receive IV while they are there? Who receives occupational therapy? Who receives physical therapy? All of that up front so that you can talk about the services that are provided. We also learned halfway through our work, we began our programming in 2020. We had been talking to NILAG and our wonderful colleagues in population health who had been doing the research and investigating about medical respite since 2018, that people with behavioral health needs who may not have a clinical or purely physical need for respite also benefit from going to respite as well. And the outcomes that we're currently exploring are the locations people go after respite, as well as readmission rates, emergency room usage, as a way to look at the advantages of respite. Next slide, please. This is Pride. We are so extremely proud of the work that our medical respite providers have done in terms of being able to help our discharged patients to move on to more stable housing. 40% of people who go to respite do move on to more stable housing, including family reunification, supportive housing, and private market housing. Many of the folks who return to shelter, it's because we live in New York City. Thank goodness everyone has a right to shelter. So many of the folks are undocumented, and that's their only solution. And then we also find people who just leave. It is a voluntary program, so people are not required to stay at respite. So when the rules in terms of being able to make sure that you are being mindful of all of the other people staying at respite, sometimes people find that too restrictive and they leave respite. Next slide, please. I wanted to be sure that I told this wonderful group that Health and Hospitals plans to release an RFP in the next few weeks, where we will be looking for medical respite operations and service providers. We want to be able to increase the number of beds that we have in Brooklyn. So we're looking to be able to have 25 beds in Manhattan, 25 beds in the Bronx, and 25 beds in Brooklyn. We're also in this RFP going to be looking for service providers who will do housing location and placement services in order to be able to assist our patients who are experiencing homelessness, the skills and help to be able to get through the housing process and to be able to locate housing using their vouchers. And the very last slide is me being extra excited about our new team at H&H. We are the Housing for Health team because homelessness is such an issue for our patients. We've developed an entire new team that only focuses on these individuals and providing the support that they need through our interagency collaborations, looking at our land as a way to be able to leverage housing units for our patients. Thank you so much for your time, and I'll pass it on to the next person.
Thank you, Marjorie. And now we'll welcome up Elizabeth Odens from Empire Blue Cross Blue Shield.
Hi, good morning, everybody. So happy to be here. Yes, I am from Empire Blue Cross Blue Shield Health Plus. We're the New York the Medicaid team for the Empire Health Plan. And through the health plan, we cover 500,000 Medicaid recipients, primarily in the New York City region. Of those, probably at any given point in time, close to 5,000 are experiencing homelessness. So we've definitely been focused on this population, since the advent of the mandatory enrollment of individuals experiencing homelessness into managed care. I won't repeat what all my wonderful colleagues have said, but like our hospital colleagues, wanted to talk a little bit about how we as a managed care organization got involved in the respite space, what our sort of path has been, what kinds of lessons we've learned, what challenges we've encountered. So we began purchasing medical respite beds about a little over 2 years ago from Communal Life. They have been our partner throughout this. We also began, we began exploring this quite a bit before that, about 5 years ago, really solving for some of the gaps that have already been called out. But certainly those individuals who were admitted to the hospital who couldn't be safely discharged didn't have a safe or appropriate setting to go to. But we also had other challenges to solve for, like people who couldn't access chemotherapy or surgery because of, they didn't have a stable place to be to get those services, or people who couldn't access needed skilled nursing services because there would be a discharge question at the end of that stay. And we were certainly seeing people who were being readmitted to the hospital because of, a gap in the planning at the previous discharge, either from acute hospital or from skilled nursing, and unfortunately usually coming back to the hospital in much worse shape. We definitely needed to, well, actually, let me back up. So we started doing that exploring really almost 5 years ago. We were very fortunate to be connected through the Bronx Health and Housing Consortium with colleagues at Montefiore, with Deirdre, and with our Communal Life partners. And I do see, the early champions of medical respite on this, on a participant list today. So a big thank you to all who've really kept this conversation going. And for us, it was really important to have that networking opportunity to be connected with the people who'd been doing, who'd already started this work, and we've learned tremendously from our partners. So we did need to make a clinical and a business case to the company. The clinical rationale was pretty straightforward. Everybody's talked about the million reasons that this makes sense. From a business standpoint, we worked with our business analyst to look at utilization, to look at our members experiencing homelessness who had medical or surgical admissions, and then to look at the potential utilization with and without the respite service. I will say that compared with the hospitals, we probably have more focus on readmissions and other service utilizations than necessarily on length of stay. But we're looking at all of that utilization. We were lucky, as Deirdre mentioned at Monty, we were lucky that our leadership really recognized the clinical importance of this, and it, the business case made sense. It has not been a difficult case to make at the company. And the other thing that made this just really possible is having an available, willing partner in Communal Life. We, of course, had some challenges. One of them, just funding mechanism, because typically in Medicaid managed care, the funding is tied to, the spend is tied to the individual, and for a discrete set of services as defined by the state. And since that's what we're here talking about, is having this service really defined by the state, and for us, logistically, having codes, having rates, things that make the funding easier. So we, like hospital partners, have been contracting specifically for beds. We've been using administrative dollars to do this, and we did start with 2 beds. The other challenge is really we're a big company, and so contracting with us, not always the easiest thing. And our procurement partners, this is not a service that they're used to, and we're working with partners who aren't necessarily billing in Medicaid or working with big companies. So definitely had a lot of support at the New York plan in navigating those, navigating that pathway and really translating what this service is to our business partners so that we could move forward. In terms of lessons learned, I would say, as everybody said, well, one, partnership is key. Communication as part of that partnership is incredibly key. So communication up front and then ongoing. So, we had the opportunity to meet with colleagues at Monty to understand what they were doing, to go to Communal Life, to meet with the potential partners, to see what respite looked like, to have a lot of discussion about what were the shared expectations. As Deirdre already commented, Communal Life's eligibility is our eligibility. So really making sure that we were all on the same page and understood that. And then ongoing, we've had weekly clinical meetings to to jointly discuss our members who are in respite with Communilife. The other thing also, similar to what's been said, but having a clear point of contact in each organization. And so for us, all of our referrals come through our housing work group, and specifically Dr. Weinberg, who will be on some of the breakout sessions. But having that point person has made it, just a lot smoother. But also ensuring that those who are potentially referring or going to be discussing respite with the members really understand what it is, what it isn't. So ongoing understanding has also been discussed. I think other things that we found, one, it started slower than anticipated. I mean, we'd been told to expect that, and Communilife communicated that to us, and we had heard that from our national partners. But just, I would say that to anybody else who's starting out in this, we thought there would be a flood, and we would immediately have more people than beds. But it was a slower start while we sort of figured out this communication and referral pathways. And even when we think it's a great option, there are individuals who aren't interested or don't feel that it's a good option for them. And so really respecting that personal decision. We have needed data just to continue to demonstrate the success of the program and to get the funding renewed logistically and importantly. Not a lot of data. And I think for partners, we don't need a ton of data coming back from the respite. There are things that we do need. Number of members referred, number admitted. I mean, we partially have that too, obviously. Reasons they're not admitted. And that's always a learning opportunity for us, as well as the ultimate disposition and, the number housed and where else people went. Internally, we're able to generate the data about what's been the impact, what do inpatient admissions look like? What do ER visits look like? So the necessary data, is a combination of that we get from our partners and internally. So when we look at, our outcomes so far, I think the most important has been the impact for our members through respite, through the partnership with Communilife. Our members have definitely had access to needed services. They've caught gaps in the discharge planning when services, when services weren't, aftercare wasn't set up, or realistic aftercare wasn't set up, or somebody missed an appointment. I mean, it's been invaluable to have their partnership in ensuring that people get what they need. We've seen, from an outcome standpoint, we've seen significant decreases in inpatient and ER use for the members who've gone through respite. We've also seen, I think I said decreases, I meant to say decreases. We've seen increases in primary care and health home connection, and again, as we would want. And then ultimately, the majority of the members who've gone to respite have moved into some more permanent housing setting. They've either through supportive housing, through family reunification, and ultimately, that's a big part of what we as a payer and a referrer are looking for. So overall, it's been a fantastic option for our members with the greatest needs, and a terrific collaborative experience. And looking forward to collaborating with all of you as we move forward in this together.
Thank you so much, Elizabeth. I know we've shared a lot with you. We are excited to have Raimundo here with us, who has gone through the Communilife Respite program. And I'm going to start with a couple questions for him, and then we're going to start taking some of your questions. So Raimundo, welcome. Thank you so much for being here.
Thank you, Bonnie. I'm Raimundo Alvarez Quattrochi, and I did come through the Communilife program. I got there in January of 2021, and I was discharged in June of 2021.
How were you referred into the program?
The referral process was a little bit different than what I've been hearing, and I think it's because I came through the health and hospital system, and the social workers there have 40, 50 patients, and they're not always able to pinpoint exactly where a patient needs to go. And I think it's just more of a training thing. I found medical respite. I never heard of it. I didn't even know what it was. One of the patients mentioned it to me. And when I mentioned it to the social worker, she goes, "Oh yeah, that's a great idea." so like I said, it's not necessarily that I was referred, but I got information from another patient. And when I spoke to the social worker, she was very excited about it. And again, I just think there needs to be a little bit more training, not just in health and hospitals, but all the hospitals and referral systems in order to, as it's been said here, to move people into what is the most appropriate place that they need to be at whatever level of care that they need. I ended up at the hospital. I had a nervous breakdown. I went through a really, really bad divorce, and I have Crohn's disease. So the nervous breakdown ended up creating really bad issues with the Crohn's. I was in the hospital for almost a month. But 2 weeks into that, I probably could have been released, but they were concerned about I couldn't be alone. So they were concerned about me not being alone because if something happened, that it was just not appropriate. So I was called as soon as the social worker and I discussed it. I was called within a day or two from I believe her name was Yashira, yeah. And I had about 5-minute, 10-minute conversation with her. And within a few days, I was accepted and I was brought into the program. I was at the Communal Life on 174 or 147 in Harlem, and everyone from the security guard all the way up to the director was absolutely wonderful. I had a really great experience. From the minute I walked in there, I felt like I felt comfortable. I felt like that people cared. I was told that it was a 3-month program, but at that time there was a lot of stuff going on with COVID, and they were still accepting COVID patients on the 4th floor. As far as I know, they don't do that anymore. But so I was given a couple more months to be there until we kind of figured out where would be the best place for me to be. Originally, they talked about a scatter site, and I was pretty against that because I didn't feel like I was ready to do something like that, and I really didn't want to be living with someone like that. At least not right away. At least I was just coming off a really horrible divorce, and I just really just didn't want that. And then, like we said, they had found the place that I'm at now, and I'm at supportive housing. I've been here since June. I'm in the Bronx. It's a really nice program, and I can't say enough good things about the people that sent me here from Communal Life. Liz, who's the housing coordinator, she worked tirelessly. She worked effortlessly. I mean, she was constantly on that phone, constantly texting me, okay, we got you another appointment here. We got you another appointment there. Let's check out this. Let's check out that. And even when I moved out, she followed me for 3 months. And yesterday I got a text message from her. So it was just really kind of nice from like beginning to end, everything. It was way more than I thought it was going to be. Like I said, I never heard of a respite. I never heard of anything like that before. And it was just such a positive experience that when Bonnie asked me to speak, I was like, absolutely, because like I said, for me, it was and is it was such a great experience. I didn't know what to expect, but I sure as heck wasn't expecting the care, like the absolute care that these people showed towards me and the other people that were there. It wasn't like a bunch of people looking, just wanting a paycheck and just, okay, yeah, get out of here. I don't want to see you. It was constant. Like, how are you? Hey, what's going on? All throughout the day, the whole time I was there. So let me be quiet because I know we're kind of behind schedule. So, but again, it was a really, really great experience for me. Thank you so much.
Thank you so much, Raimundo. It's so nice to hear what a great experience you had in the program. And I think for those of you listening and thinking about a potential program, like the importance of, I think from both Emmanuel and Raimundo, of the care and stability that they received in the program being kind of the most important thing. So really appreciate your feedback. I know that we don't have as much time for questions as we had hoped, but there have been a lot of questions about how the program is financed. And so I want to bring our speakers back, and I'll provide a bit of clarity. So the way that it exists right now is that the contracts are directly between the payer, which is either the hospital or the MCO, and the respite provider to purchase beds. So this isn't, at this point, a program that anyone can refer a client into. It's exclusively for those who are paying for them, but that's where the Medicaid pilot is going to come in, and we're going to talk about that in the following session. So really encourage you to join for that. But would any of our speakers, maybe on the payer side, hospital, talk about how, as much as you're able to share about the payment structure and how the program is financed between you and your organization and the Respite program.
I mean,
Hi, Bonnie. It's Deirdre. Hi, everybody. So for Montefiore, our contract is, like I said, we have a daily rate with Communal Life, and we'll pay for that bed regardless of usage. But it's built into the hospital budget, so it has been so successful that it's just part of the budgeted costs in the hospital. And you know, and regardless of patients' insurance, we take Medicare, Medicaid, undocumented patients. It doesn't matter. The patient's insurance is not a factor in placement and respite.
And this is Elizabeth. So from Empire, as you said, Bonnie, this will change as we, with the pilot, but currently, similar to Monty, we have a direct contract with Communal Life. We pay, what turns out to be an annual fee really to have those beds available. So we've got 2 beds, our responsibility to refer and to fill, because we're paying for them throughout, and they do come out of administrative managed care dollars rather than specific to a Medicaid recipient. So we work internally with the company to renew that contract and to renew that payment. And the only other thing is because we are managed care, we do not have undocumented individuals. So, I mean, it's available to any of our members who, meet the need and for whom it may be beneficial.
And quick follow-up to that, particularly for the health plans, does your member have to be hospitalized to begin the referral, or are you able to refer them from the community or wherever they are?
Yeah, it's logistically, it can be easiest to refer them from the hospital, but it's not a requirement of ours. And, we have had a couple of people we've referred either who are in skilled nursing or may have been hospitalized, but at this point are in the community. It's just the logistics of coordinating that with Communal Life, because they then do, they do their assessment. So it's a little easier to coordinate in the hospital, but Communal Life has been super flexible and collaborative about helping us to do that. So no, not a requirement that they're coming, that they're in the hospital at the time of referral for us.
Well, I'm so sorry that we are at time, but we have sessions tomorrow that are specifically to get into all the details. So we really encourage you to join for those breakout sessions tomorrow. We'll talk about the nuances of program design, so we can get to more of your questions in those sessions. I'm sorry we couldn't get to them this morning. Please also hang on, have a quick half-hour break, catch up on your email, and join us at 11:30 to learn more about the Medicaid pilot for medical respite, because that will open up access to people beyond those who have direct contracts that we've heard about so far. Thank you all so much for joining, and we'll see you in a little bit.